The visible decline of the National Health Service is often blamed on a lack of funding or rising demand, but the evidence suggests a structural cause. The system is operating exactly as its modern governance architecture was designed to. At its foundation in 1948, the service operated on a clear legal principle. The Secretary of State for Health held a strict statutory duty to provide medical care to the public. This created a vertical chain of command. The highest level of government was directly responsible for the well-being of the patient on the ward. Under that original model, operational failure carried direct legal and political consequences for those at the top. The government owned the risk. That accountability chain was intentionally severed. The Health and Social Care Acts of 2012 and 2022 rewrote the constitutional DNA of the health service. The minister's legal duty to provide care was erased. The unified structure was replaced by a fragmented, corporate model made up of autonomous hospital trusts and integrated care boards. By granting these bodies autonomy without liability, lawmakers created an accountability void. Administrators now prioritize institutional protection and budget targets over patient safety because they face no direct legal consequences for systemic failures. This decentralized model functions as a legal shield, protecting ministers from the operational consequences of the service's decline. On the clinical frontline, this constitutional void manifests as a daily, lethal bureaucracy. It operates through a mechanism called the governance trap. Hospital administrators engineer internal guidelines that directly override a doctor's statutory clinical duty to preserve life and prevent harm. Consider the treatment of ADHD and complex mental health patients. Integrated care boards deploy shared care agreements and restrictive medication bridging policies to ensure care is administratively blocked. These guidelines legally paralyze general practitioners. Administrators frame the rules to make doctors feel personally liable, risking their own medical licenses if they prescribe life-saving medication against local financial orders. This forced denial of care places clinicians in a state of ethical entrapment. They are ordered to watch their patients suffer. This impossible conflict is the root cause of moral injury, leading to the psychological destruction and mass exodus of the clinical workforce. Modern NHS bureaucracy exists to transfer legal liability onto frontline workers and enforce the denial of treatment. If the administrative machinery is explicitly designed to deny care to public patients, what exactly is it saving capacity for? Introduced in 2012, the 49% private income cap permits foundation trusts to generate half their income from private patients. This incentivizes trusts to divert senior capacity, ICU beds, and operating slots away from public patients to service this lucrative private arm. Complex, high-risk public patients, who represent a cost rather than a revenue source, are discharged prematurely into community voids simply to protect the hospital's corporate league table metrics. The system operates as a taxpayer-subsidized engine for private healthcare, creating a two-tier structure that prioritizes fee-paying patients over the most vulnerable. The human cost of these perverse incentives is a silent pandemic of preventable mortality. At the Tees, Esk, and Ware Valleys Trust alone, 198 self-inflicted deaths occurred, while administrators repeatedly ignored formal warnings from coroners. Meanwhile, forensic audits revealed that over £61 billion were wasted on failed mergers and digital stagnation over 2 decades. Yet hundreds of NHS executives receive compensation packages exceeding £250,000, collecting bonuses while their trusts hold open, unresolved patient safety reports. The architecture of the modern NHS rewards executives for financial extraction, while patients literally pay with their lives. To arrest this collapse, lawmakers must implement a clinical primacy clause. This would mandate that a doctor's statutory duty to save a life permanently and legally overrides any administrative budget restriction. Furthermore, Parliament must enforce executive financial accountability. Executive bonuses and salaries must be legally tethered directly to patient safety metrics and strict compliance with coroner reports. The solution to the crisis is not further privatization, nor is it another structural reorganization. The only way to save the system is to dismantle the corporate shield and legally enforce the founding promise of the NHS Constitution.